Hey everybody, welcome back to the ECG of the day. My name is Reid, and before we get started, you can download the PDF of today's ECG down in the description so that you can follow along and make your own notes. And feel free while you're down there to like this video and subscribe to the channel if you want to see some more daily ECG videos. So let's jump into it. So first thing I like to do with these ECGs is look at the forest, and the trees of the forest are my QRS complexes, and so maybe I'll choose this rhythm strip down here at the bottom. I see I've got a regular narrow complex rhythm. It seems to be going at a quite nice kind of rate and rhythm here, and then I get this pause. So we've got a little bit of a pause, and then it seems like we resume our normal, or I guess the typical pattern that we previously observed. So there's some type of pause. So we need to come back and evaluate this pause. But when I look here, I see it appears that we've got P waves before our QRSs, and so that's reassuring. And the rate of our kind of normal beats here, I would say, this is a decently on a solid line here, so I would say 300, 150, 100, 75, 60, probably 65 beats per minute or so. And so let's kind of go through our algorithm. So first thing we're going to do is we're going to evaluate for atrial activity, which is going to be our P wave. And so I see that we have P waves. It appears between or before our QRSs. Those P waves are upright in lead 1, and they are upright in AVF. It tells me that they're going down to the left, that they are most likely a sinus P wave. Next thing I'm going to do is evaluate for my EV node. And so what I like to do is just pick one of my PR intervals, maybe this first one here, and I see that my PR interval, if my start of my QRS is there, start of my P wave is there, my PR is in between 120 and 200 milliseconds, which is 3 to 5 little boxes, and so that's a normal PR interval. And what we need to do is we need to scan through the entirety of this rhythm to make sure that those PR intervals stay the same, right? Because this is just a snapshot of the AV node on one beat. And especially when we have a pause like this, we want to see, is that pause due to an AV block? And so as I kind of look through here at my PR intervals, we'll do it in V5. See, I've got, here's my normal PR interval, normal, starting to seem like it might be getting a little bit longer. And as I scan through to this one, my PR interval, my P wave starts right around there, and that is maybe 6 or 7 small boxes. So I would say it appears that my PR interval is very, very subtly increasing until this P wave is blocked. So notice here I've got a P wave, and that P wave appears very similar to the normal sinus P waves, right? Because what we need to do is, we're getting a lot of data right now to say that this is a second degree type 1 AV block, right? Where the PR interval, so my PR is increasing, and then we have a block or a dropped beat, right? Which is kind of contributing to this pause. But something that we just need to make sure is that this P wave that we initially kind of noted here, I'll do it in blue, that we need to make sure that this P wave is not a premature atrial contraction. So what we can do is we can actually measure the P to P intervals, and so maybe I'll measure from this P to this P, and the distance here is going to be something around 5, 10, 15, 20, maybe 24 millimeters is my P to P interval. And we can do the same thing on this P and help us determine if it's about the same. And so we've got 5, 10, 15, 20, around 25. And so that's 25, which is expected to be a little bit different with sinus arrhythmia, but it's definitely not a premature beat. So that's a sinus beat that comes on time and is blocked. And so in the presence of a PR interval that is slowly increasing, we would say that this is a second degree type 1 AV block. Alrighty, so we've got a second degree type 1 AV block here. And so evaluate our QRS complex. Our QRSs appear to be narrow. If I measure them, they are around maybe 110 milliseconds, which is normal limits is, I like to say 120 and less. Some people call it 100, that's okay. My QRS complexes are upright in lead 1, but they are downgoing in AVF. So it tells me that they're going away from AVF but towards lead 1, so somewhere kind of up and to the left. And you can see that my lead 2 is also negative, so I know I've got to be going away from lead 2, so really it's somewhere in this region. So we got left axis deviation, so we have some left axis deviation. What are some causes of left axis deviation? Well, maybe left ventricular hypertrophy, left bundle branch blocks. And so we can kind of start to sniff out maybe what would be causing this. And what you notice here is we've also got maybe some interesting R wave progression here in V1, V2. Not so sure kind of how to think about that. It could be lead placement. I'm not really going to really perseverate on that too much. And then the next thing I'm going to do real quick is evaluate my QT interval. I may pick an R to R, and from there, the midway point, my QT or my T wave is terminated by then, so that's good. That's normal. And then now, my last part of the rhythm analysis is going to be to look for pathological Q waves and ST or T wave changes. That's going to tell me about any ischemic changes that I might have. And what I notice, first thing I notice, is that I've got these deep Q waves in my inferior leads, right? My inferior leads start off with these Q waves, especially leads 3 and especially leads AVF. So leads 3 and AVF have pathological Qs. And that tells me that at some point in the past, we would call it age indeterminate age indeterminate MI, meaning that in the inferior region, which we know that leads 3 and AVF are in the inferior leads, right down here, there was a myocardial infarction. We don't know if it was 2 years ago or 2 hours ago, right? But there is one feature that is not associated with the Q wave that kind of tells us when it happened. And you can see we've got these kind of biphasic ST and T wave segments. Really, these T waves are like biphasic inverted. And so that is a sign of, there's a certain predictive pattern of ST and T wave changes that occur as an MI progresses. And so these are really signs of a subacute myocardial infarction, these biphasic inverted T waves. And so that should tell you that this MI might actually have been something that has been as recent as, the last couple of days. And so it's kind of like this injury pattern, almost like a recovery pattern that you see as the ECG is recovering back to its new baseline. So I would say that gives us evidence that this age indeterminate MI might actually be more of a recent subacute event, meaning that the chest pain didn't start 2 hours ago. And so that might make sense, right? We've got this second degree type 1 AV block. So the AV node, in this case, the AV node has some type of damage. And so do our inferior leads, right? Our inferior leads clearly have some ischemic changes. Now, I want you to remember that the inferior leads, right down here, especially leads 3 and AVF, they represent this inferior territory, kind of the inferior territory, which is supplied by the right coronary artery. The right coronary artery supplies that territory. That right coronary artery also supplies the AV node with blood supply. So if you had a right coronary artery occlusion, which we might be seeing here, you would have some inferior ST changes. And potentially, you could be, if it's proximal enough, you could have AV node block. And so when we put this all together and we try to map out the anatomy, and does the anatomy make sense? It does. And so what do we have? We've got a sinus rhythm with a second degree type 1 AV block at a rate of roughly 65 beats per minute. We've got pathological Q waves and subacute kind of ST-T wave changes that make me think that this has been a recent insult to the inferior myocardium, which might also explain why our axis is deviated away from that region and towards the left. Right? If this inferior wall is damaged, then we're going to have signal going away from that towards the lateral wall. So, I hope this helps. If you have any questions, throw them in the comments. And remember that coronary artery anatomy, and it can help you, especially with these inferior wall MIs. So, I hope this helps. And if you have any questions, like I said, I love answering them. And if not, we'll see you tomorrow. Have a great day.